بسم الله الرحمن الرحيم. النهاردة المحاضرة بتاعتنا هنتكلم عن موضوع مهم وهو Stable Coronary Artery Disease، وده recently another term is used called Chronic Coronary Syndrome. وأنا معاكم أنا الأستاذ الدكتور حاتم عبد الرحمن الحلمي، Professor of Cardiology جامعة أسيوط. First of all, we have to know something about the pathogenesis of coronary artery disease and atherosclerosis. Atherosclerosis is a basic mechanism for the development of coronary artery disease. طبعا في أسباب تانية للcoronary artery disease، لكن الحقيقة atherosclerosis is the basic mechanism. طيب atherosclerosis ده بيحصل ازاي؟ There are some predisposing risk factors for the development of atherosclerosis, and they are classified into modifiable factors and non-modifiable factors. Modifiable factors يعني we can intervene with these factors to decrease the incidence of the disease, such as hypertension, diabetes mellitus, hypercholesterolemia and smoking, and non-modifiable factors such as positive family history, including genetic risk, advanced. This slide shows an important item to explain how atherosclerosis develops. That is the concept of endothelial function. Now we have to discuss the normal structure as well as the normal functions of the endothelium. أولا the structure of the endothelium، وده كلنا درسناه في histology. The endothelium or the vessel wall as a whole consists of three main layers: intima, the innermost layer; media, the middle layer; and the adventitia or the outermost layer. Number one, the intima, three main structures. Number one, the endothelium, that is the structure important for the development of atherosclerosis, single layer of squamous cells tightly connected together with gap junctions. Then the subendothelium connective tissue layer, and then the internal elastic lamina separating the intima from the media. The second layer is the media. Successive layers of the cells, smooth muscle cells arranged along the longitudinal axis of the vessel wall and control the vasomotor trunk. It is separated from the adventitia by the external elastic lamina, single layer of elastic tissue. The outermost layer or the adventitia, it consists of dense collagen bundles containing the blood supply or the vasa vasorum and the nerve supply or vasa nervosa of the vessel wall. Then, what are the normal functions of the endothelium? There are several important functions of the endothelium that protect the vessel wall against atherosclerosis. Number one, barrier function. Barrier function. We mentioned that the squamous cells of the endothelium are tightly connected together through gap junctions. This is important to prevent diffusion of substances in the lumen of the blood through the endothelium into the subintima. Number two, control of the vasomotor tone through the production of certain substances that control the vasomotor tone, including number one, endothelium derived relaxing factor or nitric oxide, which induces vasodilatation of the smooth smooth muscle fibers. And number 2, endothelians 1, 2, and 3, which produce vasoconstriction of the vessel wall smooth muscle cells. Number 3, growth control, production of certain growth factors whose important functions to induce healing of the vessel during injury. And number 4, anti-thrombotic function. Number 1, nitric oxide has an antiplatelet function. That's number 1. Number 2, production of heparin-like molecules on the surface of the vessels that prevent coagulation factors. The main event that triggers atherosclerosis is endothelial dysfunction. How endothelial dysfunction occurs, leading to atherosclerosis? Number 1, increased plasma cholesterol level, or other factors such as hypertension or diabetes mellitus. One or more of these factors result in changes in the endothelial permeability that allow migration of lipids, particularly low density lipoprotein cholesterol, into the subintima. Number 2, circulating blood monocytes get adherent to the endothelial wall because the dysfunctional endothelium produces certain substances called adhesion molecules such as vascular cell adhesion molecule and intracellular adhesion molecule, and selectins, particularly selectin P. Then they, after getting adherent, they undergo migration into the subendothelial space. Once in the subendothelial space, they acquire number 3, low density lipoprotein cholesterol in the subendothelial space undergo oxidation into oxidized LDL. Then the oxidized LDL will become engulfed by macrophage cells derived from blood monocytes to form foam cells. Accumulation of more and more foam cells lead to the formation of small nodules protruding to the lumen called fatty streaks. Accumulation of more and more fatty streaks, in addition to migration and transformation of vascular smooth muscles from the media into the intima, lead to the formation of the atheromatous plaque protruding into the lumen. Clinical sequelae of atherosclerosis are vessel narrowing with symptoms of angina pectoris and maybe acute coronary syndrome due to plaque instability. The term كلمة plaque instability تستدعي ان احنا نقول ايه هو الستراكشر of the atherosclerotic plaque. ايه normal anatomy. Normal anatomy and atherosclerotic plaques formed of 3 main structures. Number 1, fibrous cap formed of dense collagen bundles. Number 2, central lipid core formed of oxidized LDL, and the shoulder region, or the region at the junction between the fibrous cap and the normal endothelium. Accordingly, the atheromatous plaques are 2 types: stable plaques with thick fibrous core, small lipid core, and intact strong shoulder. On the other hand, other type is called unstable plaques: thin fibrous cap, lipid rich core, and weak shoulder due to infiltration by macrophage cells and inflammatory cells. The second type is very liable to rupture, leading to acute coronary syndrome. Pathophysiology of chronic coronary syndrome, or pathophysiology of myocardial ischemia in general. Myocardial ischemia may be due to one or more of 2 factors. The first factor is decreased myocardial oxygen supply. The second factor is increased myocardial oxygen demand. any imbalance between the oxygen supply and oxygen demands can lead to myocardial ischemia and angina. Number 1, decreased myocardial oxygen supply. This may be functional, as in cases of anemia, carboxyhemoglobinuria, or hypotension, or it may be due to mechanical obstruction of the coronary arteries due to the presence of atheroma, thrombosis, spasm, coronary arteritis, or coronary trauma. Or on the other hand, myocardial ischemia may develop as a result of normal supply but increased demands, as in case of number 1, increased cardiac output and as in thyrotoxicosis, or number 2, myocardial hypertrophy, as occurs in aortic stenosis and systemic hypertension. Clinical presentation of chronic coronary syndrome or stable coronary artery disease. The hallmark and the main presentation is symptoms, and the major symptom is the chest pain or epigastric pain that is non-traumatic in origin with components typical of myocardial ischemia. What are these components typical of myocardial ischemia? Number 1, the location. Typically, the pain is central or retrosternal with one or more of the following radiation sites: one or both sides of the chest, one or both shoulders, one or both arms, particularly the left, more on the ulnar side, it may be down to the wrist, maybe also to the epigastrium, to the neck, to the lower jaw, or to the back interscapulary. Number 2, regarding the typical pain, character of pain, which may be pressure, compressing pain, heaviness, oppressive, crushing chest pain, tightness, girdle-like pain, cramping pain, burning pain, boring pain, aching sensation, unexplained indigestion, belching, shocking, vise-like epigastric pain, atypical stabbing or knife-like pain. Number 3, as a typical presentation, precipitated by. The pain should be precipitated by any physical or emotional stress. Physical exertion, such as physical exercise, heavy meals, cold weather, sexual activity, and emotional stress is well known. Relieved by. Number 4, relieved by rest or sublingual nitrates. Number 5, duration, typically 3 to 5 minutes, in severe cases 10 to 15 minutes. If the pain is 30 minutes or more, one should suspect myocardial infarction. Associated symptoms with pain, including dyspnea, nausea or vomiting, diaphoresis or excess sweating. Walk-through angina or second wind angina. This is a term used when the patient experiences angina during the first exercise in the morning, then he stops exercise, the pain is relieved, and then when he resumes activity, no chest pain occurs. This is the mostly opening of coronary collaterals. Angina equivalent means no chest pain, but instead the patient experiences dyspnea, as occurs in diabetics and in elderly. Definition of typical anginal pain. 3 main criteria: central chest pain, precipitated with exertion, physical or emotional, relieved by rest or sublingual nitrates. Now, functional grading or functional classification of angina, the same like functional classification of dyspnea, according to the New York Heart Association mentioned before in other lecture. Now we define the Canadian Cardiovascular Society classification, and it's nearly the same classification: class 1 angina on extraordinary activity, class 2 angina at ordinary physical activity, class 3 angina on less than ordinary. Other symptoms: one may not experience chest pain at all, may experience one or more of the following. Number 1, heart failure, gradual progressive loss of contractile function of the myocardium due to prolonged significant reduction of coronary blood flow. Number 2, cardiac arrhythmias. عارفين ان الاريثميas may be due to one of 4 mechanisms. هنا هنقول منهم changes in automaticity or re-entry of ischemic myocardium. Number 3, conduction disturbances. variable degrees of heart block due to necrosis or fibrosis of the conduction system. Auscultation, usually unremarkable. Usually auscultation of ischemic patients shows nothing, but sometimes one may auscultate number one pansystolic murmur or mitral regurgitation if the ischemic papillary muscle dysfunction occurs, and number two, third heart sound or S3 or systolic gallop due to weak flabby myocardium in cases of development of heart failure. Differential diagnosis, this is very important because there are many causes of chest pain other than angina, maybe cardiac or non-cardiac, and the cardiac causes may be ischemic type chest pain as in severe aortic stenosis, severe hypertension, severe pulmonary hypertension, severe aortic regurgitation, angina blows, وناخدها في Hatem Abdelrahman, or non-ischemic type of cardiac chest pain as in aortic dissection, pericarditis, and mitral valve prolapse. Other causes: pulmonary embolism, pneumothorax, pneumonia, and pleurisy, mediastinum, esophageal causes, esophagitis, spasm reflux, achalasia, mediastinitis, tracheitis, upper abdominal, such as biliary colic, cholecystitis, cholelithiasis, and cholangitis, peptic ulcer, pancreatitis, diabetic ketoacidosis. Chest wall is the most frequent source of chest pain, particularly in our locality, as in costochondritis, fibrositis, refractures, sternoclavicular arthritis, herpes zoster before the rash, and psychiatric disorders such as anxiety, affective somatoform, thoughts, or cardiac neurosis. Very important. Now, the diagnosis of chronic coronary syndrome or chronic stable angina is based primarily on the symptoms, particularly chest pain. There are some diagnostic tests and procedures to help the diagnosis. Number one, basic 12-lead ECG. Basic 12-lead ECG. It can detect and record the electrical activity of the heart and certain electrical pattern in the form of C-segment depression can diagnose or suggest chronic coronary syndrome. But some patients, about 50% of patients, have normal ECG in between the attacks, and the ECG may change only during the attack, so that it is a weak diagnostic test. This is the pattern of C-segment depression, either horizontal in the first line or upsloping the second line, but it is normal in the third QRS compass. Here, resting ECG shows ST segment depression in leads 2, 3, AVF, and V4, V5, V6. Other diagnostic tests and procedures on the patient shows normal resting 12-lead ECG. One may do stress ECG testing. This involves taking the ECG before, during, and after exercise on a treadmill in order to show the pattern of ST segment during exercise. Patients who are at risk for a skeletal event should be referred for other tests. Number 3, after ECG and stress ECG, echocardiography. It may be resting echocardiography, which is usually normal, may show dilatation or segmental wall motion abnormalities of the left ventricle, or it may be used to do stress echocardiography. This is an echocardiography for detection of myocardial ischemia, while an inotropic agent like dopamine is used to progressively increase the heart rate of the patient, with or without atropine. Number 4, myocardial perfusion imaging. This is assessment of myocardial perfusion during stress ECG, while injection of radioactive isotopes such as thallium or technetium. And number 5 is the blood tests for screening risk factors such as blood sugar and lipogram. Number 6, test to delineate the coronary anatomy, which may be number 1, multi-slice CT coronary angiography, and this This involves the injection of contrast material into peripheral vein and then taking a photo for the coronary arteries. Or number 2, invasive coronary angiography done by injecting the contrast material directly into the coronary arteries using specific catheter called cardiac catheter. This enables the patient to see and visualize coronary and foramen malformations. Or treatment of patient with coronary syndrome. There are two lines of treatment: medical treatment and revascularization therapy. Medical treatment is the main line of therapy of patients with coronary syndrome. This involves number 1, treatment during the attack, and number 2, treatment in between the attacks. Number 1, treatment during the attack. In order to relieve the chest pain, one should use nitrates, either sublingual nitrates 5 milligrams, this is the most important one, or transdermal patch or 5 or 10 in the form of 5 or 10 milligrams. Mechanism of action. Number 1, on the coronaries. Local action, coronary vasodilatation, increasing the coronary blood flow. Number 2, systemic. It uses systemic arteriolar and venular vasodilation, linked to reduced preload and afterload, decreasing myocardial oxygen demands. What is the molecular basis for these mechanisms of action? Number 1, increased production of cyclic guanosine monophosphate, cyclic GMP, which reduces intracellular calcium vasodilatation. Number 2, stimulation of potassium channels, increased intracellular potassium into hyperpolarization and vasodilatation. In between the attacks, there are several groups of drugs aiming to decrease or relieve the attacks and to decrease the bulk of atherosclerosis. Number 1, drugs to increase coronary blood flow, either long-acting nitrates, nitroglycerin, isoforbi mono or dinitrate. Number 2, calcium channel blockers. Number 3, nicorandil. Long-acting nitrates, and the mechanism of action was described before, and the calcium channel blockers block the specific calcium, voltage-gated calcium channels. These are the dihydropyridine drugs, such as nifedipine, nicardipine, and so on, which block voltage-gated calcium channels within the endothelial cells, decreasing intracellular calcium, leading to decreased tone and vasodilatation of the blood vessels. Nicorandil, mechanism of action the same as the mechanism of action of nitrates. Number 2, drugs that decrease myocardial oxygen demands, which may be number 1, beta blockers, metoprolol, bisoprolol, and atenolol. Mechanism of action: decrease heart rate and decrease force of myocardial contractility. Positive, negative henotropic and negative chronotropic action. Number 2, non-dihydropyridine calcium channel blockers. Number 3, drugs and maneuvers to prevent the progression of atherosclerosis. Number 1, control of hypertension, obesity, cessation of smoking. And what is the role of smoking? Smoking has 2 important rules in atherosclerosis. Number 1, atherogenesis. It facilitates deposition of low-density lipoprotein cholesterol into the subparenchyma. Number 2, thrombogenesis. It enhances platelet lesion-platelet aggregation. Number 2, statins, atorvastatin, rosuvastatin, pitavastatin. Groups of drugs. The main site of action is in the liver. The target enzyme is the hydroxymethyl glutaryl coenzyme A reductase enzyme, the rate limiting step in the formation of cholesterol by liver cells, linked to decrease the efflux of LDL from the liver. Number 4, antiplatelet drugs. These are drugs that act by inhibiting platelet aggregation through blocking certain specific platelet receptors. Number 1, blockers of thromboxane A2 receptors. This is the acetylsalicylic acid or aspirin. Number 2, blockers of adenosine diphosphate platelet receptors, clopidogrel, ticagrelor. and others such as glycoprotein 2b3 receptor blockers in the blood platelets, such as thiropiban, which are parenteral drugs used in acute coronary syndromes. Metabolic drugs such as trimetazidine, mechanism of action, it acts to redirect the metabolic pathway from fatty acid oxidation, which utilizes much of oxygen, into glycolysis, which utilizes minimal of oxygen. Number 2, ranolazine, mechanism of action, inhibition of reduced sodium ion current and inhibition of sodium calcium exchanger, leading to reduced intracellular calcium vasodilation and reduced contractility. Now, the second line of therapy is the revascularization therapy. It is indicated in one of three main indications: high-risk population as in pilots, failure of medical therapy, high-risk positive stress test. It involves the use of coronary anatomy and has two modalities. According to the result of coronary angiography, one may do percutaneous coronary intervention with balloon angioplasty, mostly with stenting using bare metal or drug-eluting stents. But nowadays, most of the stents are drug-eluting stents, and this modality is used when there is feasible or optimal coronary anatomy. Number 2, coronary artery bypass surgery or CABG using arterial or venous grafts. This is performed when the coronary stenting is not feasible. And thank you.